All right, so let's talk about B-cell lymphomas. Again, I'm covering for Dr. Subtil, but I gave a talk at the Academy last year, and I'm going to give you, here there is some therapy. I'm going to bypass the therapy and just talk a little bit about some of the important issues about B-cell lymphomas of the skin. So we know that the normal skin has very few B cells. You only find a few B cells close to a nexa. Probably that's why the incidence of B-cell lymphoma, unlike lymph nodes, is very low. This is the annual incidence. We know that there is a wide variation on distribution based on geography, and that's because we are very confused about those B-cell lymphomas. I'll try to explain what's the source of confusion, but if you look at the incidence of marginal, so the main ones are marginal zone, follicle center lymphoma, leg type, and if you look at the percentages, it's all over the place. So how does the WHO classify primary cutaneous B-cell lymphoma? The majority of them are going to be indolent, low-grade follicle center lymphoma, marginal zone lymphoma. Big confusion between those two, with small percentages of the diffuse large cell and intravascular lymphomas and other subtypes. So let's look at the distribution of those cases. Overall increase with age, but interesting to know that this primary cutaneous diffuse large B-cell lymphoma leg type, the older you are, the more likely to have this type of lymphoma. So those are lymphomas with an activated B-cell phenotype, highly aggressive, typical of very elderly patients. At the opposite end of the spectrum, we have the primary cutaneous marginal zone lymphomas, which can be seen at any age, but there is definitely a subset of patients, young, especially young women. So definitely these are like female predominance and early presentation. We have primary cutaneous B-cell lymphomas, we have secondary cutaneous, so any advanced nodal or extranodal B-cell lymphomas can involve the skin. Sometimes, for the pathologist or clinician, it may be difficult to know whether you are dealing with a primary cutaneous or a secondary cutaneous. So in general, the secondary cutaneous are multifocal, larger, deeper, a more pure population of tumor cells. As broad lines, those clues may help you a little bit. And any subtype of systemic lymphoma has been reported in the skin. So the ones that you are going to encounter, both dermatologists and pathologists in your clinical practices, for the most part are going to be the low-grade B-cell lymphomas. And the big question is, are we dealing here with a low-grade B-cell lymphoma, or are we dealing here with a pseudolymphoma? And again, it has a big repercussions for the patients. And you'll see how it's not so difficult. Those are typical cases of cutaneous lymphoid hyperplasia. They tend to be single lesions. They tend to have a specific sites like ear, nose, the nipple, the scrotum, common places. And they respond well to surgery. You're going to find germinal centers. The germinal centers are completely normal looking. You don't have any, not much irregularity. They have this gradient of growth that reflects a benign morphology. Histologically, you see those nuclear debris-laden macrophages, tingible body macrophages, centrocytes, mitotic rate, typical morphology of a germinal center. Some of those cases are due to like plastic surgery, like this patient. You may even detect the metal by X-ray spectroscopy. So when you see a case of a cutaneous lymphoid hyperplasia, the first thing you have to do is consider a reactive condition. Has the patient had any surgeries, a foreign body, tattoo, vaccine, acupuncture? So is there a reason why this infiltrate is there? A tick bites, not so much mosquito bites, but tick bites can cause very profound, what's called lymphadenoma cutis, a very reactive process. Lupus paniculitis, morphea profunda can have this type of germinal centers. A lymphomatoid folliculitis on the face, with rupture of keratinous cyst can also have germinal centers. Rarely, those other conditions can have it too. Then there are two conditions to be very aware of. One is IgG4 related disease. Those patients can present with facial lesions besides GI tract and other locations. They have a lymphoid infiltrate with lots of B cells, lots of plasma cells. You can have germinal centers, a very sclerotic background, and if you do an IgG4 on serum or at the tissue, you'll find the predominance of IgG4. IgG4 usually is not seen. So those cases of plasma cell-rich reactive lymphoid process, look for IgG4. Another condition in Asian patients is what's called Kimura's disease. They often have lots of eosinophilia in the blood or in the background, hyper IgE, they often have a nephrotic syndrome, less fibroplasia, and often with fewer IgG4 plasma cells. As we mentioned, Borrelia can cause a reactive process. Borrelia in Europe has been reported associated with lymphomas, not so in the United States. We'll talk about that. Now, we know that primary cutaneous marginal zone lymphomas and probably even all the extranodals, they may go through a chronic reactive phase. So how do we distinguish those three conditions which clearly overlap? Reactive process is not going to have a positive B cell clone by molecular, no evidence of light chain restriction. If you find light chain restriction and a positive clone, you may call it marginal zone lymphoma. Follicle center lymphomas may have light chain restriction at the membrane, but not by mRNA or protein level. So purely at the surface. Those two are going to have positive clonality. So in broad terms, is what may help us, the tools that may help us distinguish those two conditions. Now, let me show you an example of a patient of mine. This patient had Hashimoto's thyroiditis. Early on had a polyclonal cutaneous lymphoid infiltrate, polyclonal by immunohistochemistry, but in situ hybridization, polyclonal by PCR, eventually, or after 1 year, evolved into a true lymphoma with a positive kappa-restricted process and positive clonality. When we review the histograms of the clones, the same clones were seen early on, but again, the same issue we saw earlier with those subclones of CTCL. So the report you get from molecular is not very precise, and those evolving clones from a hyperplastic process to a quote-unquote true lymphoma, they may not be reported. Interestingly, many of those marginal zone lymphomas often have a predominance of CD4 cells. In this case, we did flow cytometry. A big predominance of CD4 cells and often have small amounts of T cell clones. So marginal zone lymphomas in the skin often are driven by T cells. This could be a process related to autoimmunity or could be a process associated with a peripheral T cell lymphoma. We've seen a number of cases like this report. Patients with angioimmunoblastic T cell lymphoma, follicular T helper driven, develop multiple skin infiltrates over time, which may be monotypic or polytypic. And when you find patients with one lesion is kappa restricted, the other one is lambda restricted, be aware that you have a T cell driven lymphoproliferative process. Look for those called T cell lymphomas. The skin lesions may present before the nodal lesions. MZLs are often very T cell rich, often this pattern of central B cells, peripheral T cells. So again, is an entity that up until about 20 years ago, we called those cases reactive lymphoid hyperplasia. Now we have more sophisticated tools. Now we call them lymphomas, but the majority of those cases have a very benign course. So I'm pushing the WHO, slip of the tongue, that I think eventually they are going to be called like lymphoproliferative lesions because truly they do not behave like a lymphoma, like other GI tract lymphomas will act. In any case, all extranodal MZLs, whether they are cutaneous or not cutaneous, they are driven by chronic antigenic stimulation. Could be microbial, like H. pylori in the stomach, Campylobacter in the jejunum. We've seen patients with chlamydial orbital infections, Borrelia in the skin, more in Europe than in the United States, hepatitis C. Always we look for autoimmunity, especially Hashimoto's and Sjogren's. They often have also molecular defects with translocations which may be site-specific. Those translocations or chromosomal aberrations are not sufficient to drive the malignancy. They are not the driving force, but they just fuel the chronic antigenic stimulation. So you have the chronic stimulation, chronic antigenic stimulation, you have this extra acceleration of those molecular defects, which may bring you up to a lymphomatous phase, but without the chronic antigenic stimulation, it's difficult to reach this diagnosis. So diagnosis challenge, as we mentioned, they overlap with cutaneous lymphoid hyperplasia. On top of it, light chain restriction by in situ hybridization or immunohistochemistry is not always there. Clonality of the IgH gene or IgK gene is not as sensitive as the gamma TCR or beta TCR. And also we have a wide variation in the architectural and cytomorphology of those lymphomas. So just to show you the wide variation of cytology of marginal zone lymphomas. Okay, which one of the pathology residents will tell me what's this morphology here? That's what we call like monocytoid. You see very abundant clear cytoplasm. You can have more like lymphoplasmacytic in some areas or purely plasmacytic. You can have immunoblastic looking cells. So you can have centrocyte-like cells in marginal zone lymphoma. So all those types can be seen. Early MZL often has this multinodular pattern that can resemble a follicle center lymphoma. They are often mislabeled, those cases, as follicle center lymphoma. But if you look, click carefully, there is expansion of the marginal zone, and you have this plasmacytic population. Follicle center lymphomas, they hardly ever have plasma cells. You do not see plasma cells in FCLs. Perhaps they become ulcerated, perhaps in the scalp, but rarely you find this type of process. You may also have lymphoepithelial lesions. These like zoning areas which are dark and lighter is very typical pattern of those marginal zone lymphomas. Over time, those large hypertrophic germinal centers that are the factory of marginal zone cells, they become atrophic, and eventually they become apoptotic and they go away. Sometimes we only identify those remnants of a germinal center by doing a BCL6, CD30, so looking at the antigen-presenting cells or the germinal center cells. So if you have any doubt, check those margins, those markers to find out if there is any residual. So we figure out, okay, so we often have germinal centers. So is that related to a local stimulus? So we evaluated our cases, and we found that true germinal centers are seen in about 40% of marginal zone lymphomas. Poor correlation with the extent of disease, poor correlation with the history of trauma or anything else. But we've seen some interesting cases, like this patient had tuberculoid leprosy and developed multiple monotypic plasmacytic populations adjacent to the tuberculoid leprosy. So clearly a chronic stimulus driving this pseudomalignant proliferation of marginal zone cells. We've seen the same phenomenon in patients with extensive tattoos, patients with Hashimoto close to the scar, patients presenting with an acneiform eruption, and there is literature about those MZLs presenting with what may resemble an acneiform process. Maybe an isomorphic phenomenon is what triggers this chronic inflammatory phase. In general, MZLs more common in male, deep lesions, often very pruritic, and you often find a follicular prominence. Can you see here all this follicular prominence? This follicular prominence translates clinically with this periannexal distribution. Often, especially early on, you see this like vertical growth along the periannexal dermis. Over time, they become purely plasmacytic, and those cases have an we used to call them immunocytoma, primary cutaneous plasmacytoma, pure plasma cells. In Asia, they call them cutaneous plasmacytosis. Cutaneous plasmacytosis is probably the same process as marginal zone lymphoma. Some of those patients from Asia may have Castleman's disease. They have high serum IL-6. Other patients have positive clonality, so they are true marginal zone lymphomas. So I'm going to briefly talk about plasmacytomas. Be aware that the IgD secreting are more commonly presenting in the skin. Those cases are purely plasma cells. The cells are atypical, binucleated cell. Mitosis, you should never see a mitosis on a plasma cells. The presence of Dutchner bodies and markers like CD56 are going to be a red, or HMB45, a red flag that you may be dealing with a cutaneous multiple myeloma. So obviously those patients are a much more serious process. Another condition that presents with the dermal plasma cell infiltrates is the post-transplant lymphoproliferative disorder. This was strongly EBER positive in this patient post-transplant. So those cases are typically deep. Remember what we mentioned earlier, almost like a pure population of plasma cells, in this case with very minimal atypia, but very extensive involvement on all over the body, high positive serum EBV and positive monoclonality. So the prognosis of those patients is excellent. 5-year disease-specific survival for primary cutaneous MZL, 99%. In Europe, they see a higher incidence of bone marrow involvement. I think those patients, they were not properly staged early on because they had such early systemic involvement, a phenomenon that we have not observed here in the States. Very seldom they undergo large cell transformation. So MZL, is it primary cutaneous or not? Patients, be aware of the possibility of a secondary cutaneous if they have high tumor burden. Secondary, they often go to the head and neck area. Older patients, subcutaneous, and more monomorphous pure tumor populations and fewer other cells. Also, if you do IgM is often positive versus the primary cutaneous, they have more expressions of the isoforms IgG or IgA. We published our data. We found a very high incidence of GI tract disorders, autoimmunity, which goes along with the same finding we see on extramucosal MZL. So we check in all of our patients SPEBS, UPEP, Hep C, and we look for Sjogren's, Rho, and La. We check for antithyroid antibodies, Borrelia, H. pylori, because again, this communication or this relation with GERD often. I'm going to try to go fast now because I'm going to bypass. So suspect CLL if there is co-expression of CD23 and CD5. Cutaneous mantle cell lymphoma, extremely rare, a handful of cases reported initially in the skin. Most of those cases are involving the leg and have this blastoid presentation. So a big differential diagnosis with the leg type of lymphoma. So BCL1 or cyclin-dependent D1 is going to be very important to diagnose those cases. So let's talk about the other one. The important one, primary cutaneous follicle center cell lymphoma, an entity that was questioned by many hematopathologists until the WHO 2005. Why was it questioned? Because the typical chromosomal defect of nodal follicular lymphomas, the T14/18 translocation or BCL2 expression, is rarely observed in the skin. And even when it's observed in the skin, it has no prognostic significance. So it's important to look at the FISH or BCL2 because those are indications that you are dealing with a systemic lymphoma or likely to indicate a systemic lymphoma. But even if you find them and the staging is negative, does not portend the poor prognosis. So no evidence of reactive. So one of my fellows from last year is also here, Dr. Oriol Yalamos from Barcelona too. And one of the works he did is that we look at our experience with follicle center cell lymphomas, and we found that about 75% of those cases involved the scalp. Most of those patients were men and often patients with androgenetic alopecia. So there may be something going on with this androgenetic alopecia and the distribution of those follicle center cell lymphomas on the scalp. So this is what I call the aureole type lymphoma. So very frequently on the scalp, single lesions, those patients have a very impressive clinical presentation. For the most part, they do very well. You still need to stage them, but they do very well. Other patients have this miliary or aggregated facial presentation. The prognosis of those patients is good, but not as good as the ones we talked before. Relapse is quite common. We have to look for bone marrow involvement, with the exception of those scalp T1 cases that we don't do any further workup, that PET CT scan and blood work. I'm going to bypass all these cases. So important for the pathologist. The pattern can be follicular, can be mixed, or can be purely diffuse large cell. So cutaneous infiltrate of diffuse large cells could be one of those very indolent follicle center cell lymphomas. So whenever you see this type of diffuse pattern, look for any remnants of a germinal center. You may have to do CD21, CD35, but if you find any remnants of a germinal center, you're probably dealing with a follicle center lymphoma and not with the leg type, which is this highly aggressive that does not present any nodularity. So in the scalp, they are difficult to appreciate the architecture because you have all the distortion of the follicular units. Often, large B cells are very fragile, much more so in my experience than T cell large cells. So we often have all this crash artifact. Sometimes we do flow cytometry, we may be able to find a few more markers there. So the immunohistochemistry BCL2 negative, with the exception of about 10% that again does not portend a poor prognosis. FOXP1 also is a marker of activated B cells. Is seen rarely in follicle center cell lymphomas. Those patients are usually the leg type, but there is a little bit of overlap, as I will mention. So diffuse pattern can be seen. Do CD35, CD21, CD23, look for these remnants of follicular dendritic cells. As I mentioned, the molecular has no impact. So diffuse large B-cell lymphomas could be follicle center lymphomas, as we mentioned, or this leg type that's much more aggressive. There are also other cases, the blastoid mantle cell, marginal zone lymphoma that can present with the same type of distribution. So the leg type, typically elderly patients, typically woman, could be one leg, could be both legs. The more localized the process, the better the prognosis. Patients with one single lesion do very well. The morphology is very characteristic. No evidence of nodularity whatsoever. Again, very important. I cannot emphasize enough the importance of looking for any remnants of germinal centers. Completely diffuse, the cells very large, very round, very prominent nucleoli, high mitotic rate in those cases. Strong MAM1 expression, strong FOXP1 expression, strong IgM expression, negative for EBER. So IgM may help, but notice how, so we often check for IgM, but the follicle center lymphomas that happen to involve the leg, they also are often positive for IgM. So in the setting of a B-cell lymphoma diffuse large cell from the lower extremities, it doesn't matter very much whether it's a leg type or a follicle center type. Patients with this type of distribution in the lower extremities do have a poor prognosis. So activated B phenotype, the important thing for you to remember is this MYT88, which is a toll-like receptor analog that about 70% of the patients have a leucine 265 to proline point mutation, very specific for all those cases. This study was done on paraffin section, so the authors believe that even the ones that were negative are probably positive. So this may be a driving gene mutation for those patients. I'll bypass this one. Patients can present with a diffuse intravascular B cell. important to recognize because they often have CNS involvement, very aggressive. They have defects on the leukocyte adhesion molecules like CD11A or CD18. Can be primary cutaneous, sometimes within a capillary hemangioma. And then we have those EBV positive B-cell lymphoproliferative disorders, patients who are on methotrexate, elderly patients. Those B-cell lymphomas are angiocentric, strongly EBR positive. So be aware and look at how they look, almost like exactly like the ones we talked about before of those CD8 granulomatous. Big overlap between lymphomatoid granulomatosis, elderly type lymphomas, angiocentric, angiodestructive, EBV driven. This was a methotrexate patient, renal insufficiency, high methotrexate levels, and this LYP-like presentation with the same type of, I'm going to bypass all this stuff. And I think that's all I have for you. We have a lot of little zebras, but no time to discuss. Thank you all for your attention.